Hello. Today I'm going to talk about one of the most important chapters, which is diagnosis. I would often see patients come in the office, they were on some type of treatment and some idea of their primary about what their diagnosis might be led them to be on a certain treatment, but it really had not made such diagnosis. Now, some diagnoses are based totally on the history, but it's very useful to have confirmatory evidence of really what's going on with the patient, particularly when they're having trouble and it continues. I'm going to talk about a number of cases I had where there was difficulty in diagnosis, and some of this just has to do with medical approaches that are suboptimal or inadequate or even fallacious. So this patient was really going to see the gastroenterologist because he had upper abdominal pain, and he ended up getting a colonoscopy. Tried to get back into the office, and they basically stiff-armed him. He couldn't get back in. And it's sort of like, well, we've gotten our best reimbursement from this patient. We're not going to see him again. This primary can deal with this. But it would have been better to do an upper endoscopy at the time of his colonoscopy and at least try to make a diagnosis and figure out what was wrong with the patient. And I recently went to see my primary. He said all the gastroenterologists here are not seeing patients in the office. They just do procedures on them. And this can lead to problems. I think I already mentioned there was a patient who had iron deficiency anemia that went for a colonoscopy and didn't get an upper endoscopy. He should have had both, really. They just did some sort of colon screening. And then later it turned up in the hospital. I did an upper endoscopy on him. He had stomach cancer. Anyway, the diagnosis is very important so you know what you're treating. Now, I realize that some patients are worried about the risks, or they have financial problems, or they don't want to leave work, stay away from work, and may get them in trouble with their job and so forth. But you need to plow through that if possible so you can really do the best for the patient. Now, I was taught as an internist to look at the medication list. You always want to look at the medication list first and ask yourself, could this be the problem? Because patients don't appreciate being on a medication that's causing a problem and it was never recognized. You put them through umpty-ump tests and you don't find anything. So that's important. That's one of the first things you want to do. ACE inhibitors cause a chronic cough in a lot of patients, and that's really what I think of when we talk about this sort of thing. Patients who have acid reflux or ulcers, you have to remember that Nexium, Prilosec, these kind of drugs work best if you take them 30 minutes before your first meal of the day. If you don't do that, they may not work so well. Also, there are other things that need to be thought of and accomplished, and all of that's in the acid reflux chapter. In the case of acid reflux or upper abdominal pain, rather than just treating the patient, and you can find guidelines that say let's just treat the patient empirically for a period of time, but I think you're best to do upper endoscopy and see what you're dealing with. Now, if it turns out to be acid reflux and there's just some minor irritation at the bottom of the esophagus, that's one thing. Or if it looks mostly normal, you may just be treating symptoms. It's important to rule out other causes as well. But on the other hand, if there are complications of acid reflux, such as stricture or erosions or ulceration, or even lining changes of the esophagus, then that mandates stronger treatment, in particular PPI therapy, and follow-up a lot of times is indicated, especially for ulcers, rule out cancer, and lining changes. You have to follow those patients. I'm going to talk also about some cases I saw in my military career. I think one of the best cases, if not the best case I ever saw, was a young boy. I was asked to see him. I was just covering the emergency room. This was in a small town. in West Texas. And I was covering the emergency room, and there was one doctor that was there, and one little room that was the emergency room, and one prescription pad with just his name on it. And he wanted to be out of town, so he went out of town. But I was asked to see this patient up on the floor. That was unusual. The first time and only time I'd been to this hospital, which was adjoined to the nursing home. So anyway, I went up there and saw this young man, and he was being treated by his mother, who was a nurse, and she had already lost one of her children. And she was squirting water in his mouth, and he was trying to breathe. And he was supposed to have pneumonia. Well, I look at his chest x-ray. There's no pneumonia there that I can see. He's hardly moving any air. He's so tight. So he had no IV. I managed to get his IV in. I had learned how to place those. And one of the tricks was when you see the blood and you think you're in the vein, you better advance it a little bit further before you try to place the catheter in there and pull the needle out. So anyway, I got that in there. And then I looked up what I should do, and I put him on about 3 or 4 medications, including steroids, and I think I had him on IV aminophylline and all that sort of thing. And at that point, the next day, he was paraded around the hospital and looked great. So he had severe asthma, and really his diagnosis was not correct, and he really needed the proper treatment. So that was a key thing, key patient, and really could have been my best case in my whole career. There was a case in Wiesbaden. This was man was a Pentecostal pastor, and he had this abdominal pain and nausea and some diarrhea, as I recall. And we were checking out his heart because his blood pressure was, I think, a little on the low side. And we thought the man had a heart problem. He was seen by the gastroenterologist. I was an internist at the time. I wasn't specialized. And the man was really having a lot of problem at one point. And being an internist, I didn't know what else to do. I drew some blood work on him and ended up helping to make the diagnosis. His potassium was high. It should have been low. And that was a clue that maybe there was a problem with his adrenal gland. So I went ahead and I think I repeated that. It remained high. Drew the cortisol level, and I believe I drew, I don't think we had Cortrosyn or ACTH we could draw at that time. But anyway, I drew his cortisol level, started him on steroids. He said he felt like a lion shortly after that. So his cortisol level came back low. He had adrenal insufficiency like John F. Kennedy had. And then later, of course, his wife said, well, yeah, I thought his skin was turning dark. So I looked it up, and sure enough, there was some adrenal insufficiency that was mentioned. But I thought, nah, it couldn't be that. And then didn't say anything to the doctor. So always remember that. When I was chief of GI in Wilford Hall, one of our star doctors there said they couldn't figure out what was wrong with this case, and he brought me this case of recurrent small bowel obstruction that looked like something like that with abdominal pain. And it turned out it was, looking over her medications, it was related to the ACE inhibitor. She was getting small bowel edema with intermittent obstruction. And that was really a difficult case, but she did well after stopping her ACE inhibitor. There was a head nurse in the hospital, Wilford Hall, in the Air Force. Wilford Hall at that time was the main flagship of the Air Force, and probably still is, who kept having trouble with small bowel obstruction as well. And turned out she had a stricture in her small intestine from piroxicam, also known as Feldene. And she required surgical resection. After that, she did well. When I was in private practice, I saw a young man who'd seen other GI doctors, and he he had a history of intermittent diarrhea and abdominal pain. He was losing weight, and he was really not doing very well at all. And I went ahead and had to repeat his endoscopic procedures because biopsies were not obtained through the scope at the time that other procedures were done. They were just kind of looking around. Should have been doing more. And we did all of his workup and repeated it and looked at it. And then we got into stool for fat as part of his diarrhea workup. Came back negative, and I think the first test was positive, and it was a quandary, but it wasn't until we learned that he really was not, that the reason it was negative was he was avoiding fat in his diet because it was giving him diarrhea. So when we did the stool for fat on the 100-gram fat diet, sure enough, it was abnormal, and that was really the breakthrough in this case. And things became easier to pin down. It turned out he had pancreatic insufficiency, really only highlighted with endoscopic ultrasound. But then after that, he had chronic pancreatitis changes and required long-term follow-up to make sure he didn't develop pancreatic cancer. So that ended up being important, and I got a fruit basket for a while for that case they sent me. And I really ended up seeing, I think I ended up seeing him because I had seen his mother, who I had done a procedure on in the Baptist hospital. I can remember being in San Antonio, we're in the endoscopy center, and there, and and this is what happens. A lot of times people will just tell you stuff that's important in passing, and sort of pretend it's nothing. Don't really see you formally, don't see anybody formally. So he was telling me he was having some back pain. He thought it was from his gallbladder. It didn't sound quite right to me, and it was suspicious in my mind for coronary disease. This was our anesthesia professional. So I ended up getting, I knew the cardiologist, and I ended up getting him seen real quick. I told him what the situation was, the cardiologist, and they saw him expeditiously, and turned out he needed a coronary bypass. He ended up getting admitted, coronary bypass, and did well after that. And the family was very grateful that we made the diagnosis and got him the treatment that he needed. Now, this next case I'm going to talk about is unfortunate. Colleague of mine and gastroenterologist, another GI doctor, came to see me for a screening colonoscopy. And so as he was getting ready to have his colonoscopy done, his wife, who was also a physician, said, they had a lot of trouble with his sigmoid colon. Well, when she said that, I decided, well, we better do a water immersion. So we did a water immersion, and fortunately got around his sigmoid colon quite quickly. And then the rest of his colon was fine. Everything was good. And I talked to them after the procedure, and they told me that the most prominent gastroenterologist in town couldn't get through the sigmoid colon. But not just that, because he couldn't get through the sigmoid colon, he told him that he had cancer. Well, just because you fail at a procedure doesn't mean that the problem's with the patient. And I think that's a real travesty of a doctor if you tell a patient they have cancer and you really don't know what they have. And he didn't have cancer. That was just a terrible travesty of what your commitment is to the patient, what your obligation is. You're failing your obligations. I saw a young man who, accompanied by his wife, he was in construction. He'd been losing weight and having abdominal pain. They tried him on these medications. They hadn't really helped. Nothing was working. He really needed an upper endoscopy. They put it off. They were having some financial issues. And finally, when he got around to upper endoscopy, it turned out he had H. pylori, or Helicobacter pylori. Treated him for that. He was fine. So I've often been surprised at how valuable endoscopic procedures, whether it's colonoscopy, upper endoscopy, or other procedures, can be in really elucidating what's going on with the patient and making a diagnosis. One of my wife's friends, her mother, had seen a number of doctors, been found to have Clostridium difficile, went through a number of treatments, but they didn't really follow the guidelines, because when you have recurrent C. diff, you have to approach it differently. And so I put her on a long course of vancomycin with tapering, as is recommended. Finally got rid of the C. diff, and then she was fine. She quit losing weight. She did well. And then her daughter was very pleased with that. So we were fortunate with that. So if you have a patient that's difficult to diagnose, there's some things you can do. Of course, you want to do the usual things correctly. You want to take a history. You want to do your physical exam. You want to order the appropriate x-ray studies if needed. You want to order the appropriate laboratory. And then you get into possibly CT scanning or endoscopic procedures if indicated. Patient hasn't had a screening colonoscopy, that may be indicated along with it. Or it may be a diagnostic colonoscopy if you need to do biopsies or there's an abnormality seen on imaging such as CT. Also, if you don't know what's wrong with the patient, having worked them up thoroughly, get another opinion. Ask for a specialty consultation, or talk to somebody you know, or talk to an expert on the phone. Try to make a diagnosis. Be persistent. Making a diagnosis, of course, is facilitated by the physician's knowledge base and training. If you're not aware of an entity called pill esophagitis, then you're not going to think about it. I think I mentioned a patient that came into the office. She'd been in the emergency room. She had symptoms. She had pain in her chest as the main symptom. And they failed to get the key history, which is pain with swallowing. Pain in the chest with swallowing. Okay. Well, turns out she had been on Vibramycin. And if you don't drink enough fluid with that and you lie down within 30 minutes, you're going to get pill esophagitis in some cases, and it's going to hurt, and it's going to hurt like the dickens, and you're going to be in the emergency room. Well, that's what it was. Upper endoscopy revealed so-called kissing ulcers, where you have ulcerations on both sides of the esophagus. Went ahead and put her on the appropriate treatment for that, and told her what was going on. And she did well after that. Sometimes it's important to think over a case. Take your time. Stop. Think. Sometimes you have to slow down. Towards the end of my career in the military, I was asked to see the mother of a very high-profile physician and his family, about as high profile as you can get in the military. And she had this funny pain that she was having down in her lower abdomen. And I examined her, went through the history, and I really wasn't sure what was going on. And then for some reason it hit me as I came back into my office. And I went back in the examining room, and she had a hernia. It was an inguinal hernia. Well, her son, who centered in me, was a surgeon. And that same evening, they went in and fixed her hernia. Bingo. That was something. It's important to keep in mind that if you're having trouble with the diagnosis, a lot of times what's going on with the patient is a variant of a common condition rather than a very strange, unusual, or rare case. Even though those may sound more attractive, it's not usually that. Or it may be they have more than one thing going on. You have to realize sometimes in private practice that the patient is only going to go through a very limited number of tests, and you may want to order the most important ones first, rather than going through a sequence where they get tired of testing or they don't come back, or there's financial issues or insurance issues or whatever. But I never really approached it too much that way. I thought about that, and I thought, well, maybe that's not why they went through the testing or came back for the testing. But as a physician, you have to be persistent. As a patient, you have to be persistent, sometimes to really make a diagnosis. So with that, I'm going to go ahead and conclude that particular chapter.